Welcome to Osteobites, everybody. My name is Anne Graham. I'm an osteo warrior and executive director of MIB Agents. Today, we are talking with Dr. Abha Gupta on fertility preservation in patients with osteosarcoma. Dr. Gupta received her MD at the University of Toronto and completed her pediatrics residency at Yale-New Children's Hospital and Children's Hospital of Eastern Ontario before moving back to Toronto to complete her fellowship in pediatric hematology oncology at the Hospital for Sick Children. To complement her training, Dr. Gupta completed a one-year fellowship in adolescent and young adult oncology with a focus on sarcoma at the Princess Margaret Cancer Centre. She is currently cross-appointed as staff oncologist at both the Hospital for Sick Children, Solid Tumor Section, and Princess Margaret Cancer Centre. She's the medical director of the Adolescent and Young Adult Oncology Program at Princess Margaret and medical director of the Canadian Sarcoma Research and Clinical Collaboration Society group.
Collaboration.
All right. Before we get started with this essential conversation, allow me to share with you what pretty much everybody here already knows. It's Childhood Cancer Awareness Month. Every month at MIB Agents, but especially this month, we at MIB Agents honor, remember, and celebrate the kids who have suffered greatly and are suffering greatly with osteosarcoma and cancer in general. A visible sign across the country of this support, remember, and celebration are bows. These are made by families affected by osteosarcoma across the country. Please go to our website and spread awareness and sparkles, because there are lots of them, like me, by putting a bow on your mailbox door or adorn your clinic floor or research lab. Clinic packs are available for your research lab, school, institution, wherever you work, live, what have you. I kept mine on for a year. These are weatherproof, and I live in Vermont, so like they take a beating and keep on sparkling. Go to mibagents.org/bows to get yours. Dr. Gupta, would you start with introductions, please?
Thank you so much for having me here today. So as mentioned, my name is Abha Gupta. I'm an oncologist in Toronto. I treat kids, adults, young adults with sarcoma predominantly. And as you know, osteosarcoma is the most common primary bone tumor in young people.
Hi, I'm Valerie. I'm a senior at UNC Chapel Hill studying biology, and I'm a sibling of an osteosarcoma patient.
Hi, I'm Kara Skrubis. I am a junior at the University of Buffalo, and I am studying to be a child life specialist, and I was diagnosed with osteosarcoma in January of 2020.
I'm Alexis Johnson. I've been a part of MIB for a while. It holds a very special place in my heart. I'm currently in my third year of medical school, and I'm hoping to become a pediatric oncologist.
So today we're going to, our theme is talking about fertility. You know, the one thing that I always remark is our whole young adult lives, we go through, you know, our journey as a young adult, trying our best not to get pregnant until we actually want to get pregnant. And then all of a sudden, it's like, wow, can I get pregnant or not? And it's only at that time that most individuals and or couples actually, you know, have a realization of whether or not they have an ability to have a baby naturally. Most of you already know that about 15% of couples unfortunately struggle with infertility, and those who are cancer survivors have an additional factor for sure that can contribute to compromised fertility. So I want to speak about fertility for men and for women separately. I acknowledge for sure gender fluidity, but when it comes to speaking about fertility, we have to think of it, at least so far, in binary terms, those who have sperm and those who have eggs. So let's start with those who have sperm. So when a young male is born, all the gametes in that male are located in the testicular tissue. And they're basically in the form of little baby sperm. And then once that male enters puberty and enters adolescence, then those little baby sperm mature into normal mature sperm. The adolescent male is able to have an erection, is able to ejaculate liquid that contains those mature sperm in it. And that the process of little baby sperm becoming adult mature sperm that is located in seminal fluid takes about 90 days. So that process of sperm regeneration is continuous from the moment that a male enters puberty to, we'll say, the old age, like till they're 90 years old. So men have this ability to continually regenerate sperm throughout their lives. So chemotherapy drugs can affect that process of developing sperm. The process of developing sperm is called spermatogenesis. So sometimes there are some cancer drugs that can decrease the process of developing new sperm. In fact, if you check the sperm of any post-pubertal male when they're currently on treatment, whether it's methotrexate or doxorubicin or any anti-cancer drug, even if it's a tyrosine kinase inhibitor like regorafenib or cabozantinib, anything, if you measure that sperm in any male who is currently on therapy, it is possible and likely that that sperm count is going to be low, because while men are exposed to treatment, that process of generating new sperm goes down. However, the question is, what is the likelihood of that sperm, that process of making new sperm every 3 months, going to recover once the treatment is finished? So let's take a 20-year-old who's been newly diagnosed with osteosarcoma, and he is about to embark on chemotherapy with the traditional 3 drugs. And I like to call them MAP chemo, MAP, methotrexate, adriamycin, which is the same as doxorubicin, and cisplatin. So for that male who's going to go through the standard North American protocol of MAP chemotherapy, if we measure his sperm before chemotherapy starts and it's normal, it is most likely that during chemotherapy his sperm will go down. However, probably 1 year after his chemotherapy is finished, there is an over 80% chance that his sperm will have recovered back to normal, because the total chemotherapy drugs of MAP do not traditionally cause permanent sterility in men. So they don't cause permanent disruption of that process of making new sperm. As I said, during chemotherapy, sperm count may be low, maybe 3 months after chemotherapy stops, maybe the sperm is low, but the statistics and the literature suggest that at almost 80% of the time, that sperm should resume. Sperm regeneration should resume. So what do we do? In all post-pubertal males, we should still offer the opportunity for that male to bank his sperm, because, first of all, unless you do a semen analysis pre-chemotherapy, you actually don't know whether or not the sperm is normal to begin with. And just because it's abnormal after chemotherapy, unless you check the sperm before or bank the sperm before, you don't know whether or not the low sperm after chemotherapy is from the drugs or would have been low anyways. Secondly, obtaining sperm from a post-pubertal boy is, generally speaking, non-invasive. Now, of course, for sexually inexperienced males or for some cultural or religious factors, having to produce a sperm sample through masturbation and ejaculation is not so straightforward, for sure, especially for our younger adolescents. Can be quite an emotional process to even admit to their parents or to their healthcare providers that, yes, I am masturbating and I am ejaculating. My good friend and urology colleague at Sick Kids reminds me, though, that it's actually biological. Every single pubertal boy is masturbating and ejaculating. It's part of nature. It's just part of our bodies. So every adolescent boy has the ability to do it. The question is, do they have the ability to do it in a cup, in a medical scenario, and with a big osteosarcoma in his leg or arm? So nonetheless, the principle is we should definitely give them an opportunity to bank their sperm and have a conversation with them that, yes, there's an 80% chance that your sperm will be normal after your chemotherapy is done, but nothing is 100%, and if you are interested, you should be given an opportunity to do so. The other reason why I think it's very important to always have that conversation with families and patients is because what if that individual can't tolerate one of those three drugs, M, A, or P, and a drug like ifosfamide needs to be added to the mix? Or if the oncologist decides for whatever reason they would like to add ifosfamide to the mix. Well, ifosfamide is a totally different scenario than MAP chemotherapy in terms of its effect on sperm. Large cumulative doses of ifosfamide will cause permanent sterility in men, meaning that the chance of recovery of spermatogenesis, or the ability to make sperm every 3 months, will definitely be compromised if someone is exposed to ifosfamide chemotherapy. So it's always best to at least give patients and families an opportunity to think about banking their sperm prior to proceeding with chemotherapy. Whether or not they choose to bank is the patient's and the family's decision, but at least they've been given time to think about that as an option. Maybe I'll pause here for any questions.
Yes, I had a question. So Dr. Gupta, you mentioned in the beginning about some receptor kinase thing. What does that have to do with just infertility? Like that drug, how that doesn't have to do anything with like hindering infertility versus like other treatments? Like what is that mechanism you talked about for, like, in layman's term?
Great question. I'm not sure why being on an oral anti-cancer drug, so first of all, just so people know, so the word tyrosine kinase inhibitors is just the name of a big class of oral anti-cancer drugs that are now commonly being used in many adult type of cancers, and more recently has become an option even in individuals with relapsed osteosarcoma. So my only point is that at least in a few scenarios, if we measure sperm in men who are currently taking these new novel oral agents, their sperm count can be decreased while on therapy. But the likelihood is that once somebody completes or finishes that oral therapy, their sperm count should be able to be recovered after that. It's just that during exposure, for some reason, it goes down temporarily. I'm not sure about the mechanism of that, nor am I certain if it's similar across all oral anti-cancer drugs, or if it's specific.
We have the question, what if the male is pre-puberty? Could chemotherapy cause impairment of spermatogenesis before the transition occurs?
Great question. And the answer is no. So the impact on pre-pubertal testicular tissue and post-pubertal testicular tissue would be the same for any chemotherapy drug. So if someone is exposed to a lot of ifosfamide, then the impact on their spermatogenesis is going to be the same regardless of whether they're 3 or 23.
How do you handle this at your institution when somebody is newly diagnosed with osteosarcoma or any cancer where they're about to have cytotoxic chemotherapy? Like how do you address this? Is this like you're newly diagnosed, here's what you have as a cancer, here's what your treatment's going to be, here's what we recommend?
Yes, good question. Yeah, so every oncologist, I guess, has their style of disclosure in that first meeting, which is the worst when you hear for the first time, I'm sorry, you have been diagnosed with cancer. And that's, it's the worst conversation anybody could be part of on either side of the table. But the concept of introducing fertility in that conversation is that one silver lining, because it means that if we're talking about fertility and the ability to have a baby afterwards, it means that there's a future, that there's survival, that there's life. And so the way I talk about it is to say, yes, you have been diagnosed with osteosarcoma. Cure requires 2 things, surgery and chemotherapy. And the most important long-term effect of the chemotherapy that you are going to receive, is possible, is going to need some kind of heart imaging in the future. And that's it. And then I say, we also always would offer the opportunity to bank sperm because you are male and you're post-pubertal, but that's the assumption here. Even though you have more than an 80% chance of being able to have normal fertility after your treatment is completed. And then we, depending on the age of the patient, then we go into the semantics of how does one bank their sperm. And even that conversation, is actually quite important. It's not so automatic, is it, for men to think about how does that even being done, to have to go into a separate clinic, be able to actually have an erection with some type of stimulation, either videos or magazines or something else, which also is a topic of controversy for some families of younger adolescents, then to be able to ejaculate into a cup. And again, to be able to do that once you've been given this news that you have cancer. So I would never minimize that process, but at least to say that it can be done without a general anesthetic in general.
Do you also have the conversation of cost or financial assistance when you have that conversation?
Yes, absolutely. And that's a huge barrier for many families, for sure. So we speak about the cost of not only upfront freezing, but then also of the yearly storage fees. Now, at the pediatric hospital that I work at, this was such an important topic for us, and we didn't want finances to be a barrier. And so we lobbied to actually work with a fertility clinic next to us and have 25 years worth of storage covered for free for families, so they didn't have to pay. But that's just just a very one-time example that's not helpful to anybody else outside of Toronto at this hospital. So there are programs called Fertile Hope that and other programs that might be accessed to help subsidize the cost. But good point for sure. To kind of come up with $350 cash or whatever that cost is up front right away can definitely be very stressful.
I have a question real quick. Are you having this conversation just as like a future pediatric oncologist? And, when you're first diagnosed, you're getting thrown so much information. So when are you broaching this conversation at like the first meeting, or because you start chemotherapy so quick too, so you don't have that much time. So what's the best way to approach the subject? And especially if the kid's, younger and 15, like you said, it's just a very, can be a very sensitive topic, but I feel like it's important too. So I just wanted to get your opinion on that.
Yeah, for sure. And like I said, every team and every physician, nurse practitioner, healthcare provider has a different strategy. My strategy is I think about what's time sensitive and what's not. Nobody's getting their chemotherapy tomorrow. But so let's suppose chemotherapy is going to start a week from now. You're going to get a port, you're going to, there's a lot more time to talk about the toxicities of chemotherapy and the processes and hair loss and blood counts and all that. So I actually don't dwell on that stuff on that first meeting, because I know that can happen the next day, like a week from now. There's the whole healthcare team is there to help families go through mucositis and nausea, right? But the time sensitive issue is to say, this kid needs to actually be able to think about whether or not he wants to bank his sperm, and then be able to execute that banking before his chemotherapy starts, ideally. So to me, that's actually the priority of the conversation on day one, rather than, this is how you administer growth factor, like, doesn't matter, right?
Do you send them home with information?
Absolutely, for sure. We know that what percentage of that information is absorbed in that first meeting, again, after you've heard that big C word. So we definitely, we spent a lot of time actually developing patient materials that for information regarding fertility preservation, that we send families home with, pamphlets that are located on our website, which we can send the links for later. And when we speak about women, we'll also share the link for a whiteboard video that we created as well. So it requires more than one conversation for many families. First, and also, when was the last time you heard a 15 or even a 20-year-old male necessarily think about how important it is to have a biologically related child? So it's really amazing and fascinating to hear those conversations evolve to say, actually, you know what, I'm good. Like, if I'm not interested in banking my sperm, if I need to adopt, I'll adopt. Or some guys say, I really, really want to have my own biologically related child. I'm going to try my best and do this. And so the spectrum of conversations is really quite amazing and impressive. So we definitely give all males an opportunity to think about things, have some time at home, talk to their friends and family, talk to the male figure in their home that might be able to help them with the process, and then support that learning with either soft or hard materials to also browse.
Earlier, you said this is, often or sometimes a really uncomfortable conversation. I think this is an uncomfortable conversation to have with your parents in the room, like at all times. Like, this would be super awkward. Like, do you ever have parents go, we're not going to talk about that? And then what do you do? Like, just.
Well, this is the first time I've met someone, so it's not like I know them really well or have had a chance to establish rapport. So yeah, sometimes there's some awkward moments, but if I see the kid like squirming and blushing, I'm like, Mom, so do you mind leaving for a couple minutes? And I leave, actually, and I find a male physician or fellow or somebody to come in and actually do the talk, because also depending on the kid's age, they may or may not appreciate having this conversation with a female. So all of the above, for sure. Absolutely. Yes. So the story in females is a little bit different. So all females are born with 1 billion eggs, and these eggs are located in 2 ovaries. So then naturally, with time, the number of those eggs steadily declines. Starting from age 1 day of age, a female's eggs will steadily just decline. That's just the way it is, until you reach a certain threshold, usually around the age of 50 or so, when there's not enough eggs within the ovaries to sustain hormone production. And that's when a woman would enter menopause. So the decline in female fertility is a natural process and is a finite term. Unlike men can produce sperm even when they're 75. women cannot produce eggs. All the eggs that a woman has, she has at birth, and then they slowly decline. So it's a fixed pool. So now, if that ovary is exposed to toxins, radiation, chemotherapy, then if you think about that normal decline, it will just go a little bit faster depending on what that exposure is. If I take an ovary and I radiate it directly, all of those eggs will die immediately. There'll be no eggs left. If I take that ovary and expose it to a little bit of methotrexate, they'll be okay. That slope of or rate of decline of the eggs within that ovary won't change that much. So the most important factor in fertility for women is actually age. So if a woman is above the age of 35 or 40, the number of eggs in that ovary are already on that threshold of being able to create a baby naturally. So then if you have a woman who's 30 plus or 35 plus, and then that ovary gets exposed to chemotherapy, that might be enough of a push down to put that woman to get rid of all of those ovaries, or enough so that that woman's ability to have a natural pregnancy is diminished considerably. But if that female ovary is 20 years of age, she still has a ton of eggs. And so even if she's been exposed to MAP chemotherapy, they might go down a little bit, but there's still going to be plenty there with MAP chemotherapy alone for that 20-year-old to still have a period of normal fertility as she would have otherwise. It's just that if her ovaries if her eggs have gone down a little bit, then if instead of reaching menopause at the age of 50, maybe she would reach menopause at the age of 40 or late, early 40s. So that the window of fertility may be shortened, but there would be no reason to think that if she was fertile to begin with, that she wouldn't have an opportunity for fertility there after chemotherapy. So the idea of freezing eggs or saving fertility before chemotherapy in women with osteosarcoma is a totally different scenario. And Anne will share the link of this whiteboard video that I've made with my team here in Toronto to describe the actual process of harvesting eggs. Harvesting eggs is no small deal. It is, first of all, very expensive, no matter where you live. And maybe with some private insurance plans in the US, you might have some cost of that covered. It is also uncomfortable. It is an invasive procedure that requires sedation. You need to have transvaginal ultrasounds. You need to have a probe inserted transvaginally to harvest the eggs, and have those eggs then frozen. So if a woman is, for example, age 20, and she's just been diagnosed with osteosarcoma, and she's about to receive MAP chemotherapy, my conversation with her would be, you will have an opportunity to have fertility, to have a normal pregnancy following your treatment. You do not need to freeze your eggs before treatment. If, however, a woman is maybe 30 or 35, then her risk of going into premature ovarian failure or menopause because of the chemotherapy, that risk might be a bit higher. And so then maybe the incentive or the impetus to actually go through egg freezing might be a bit heavier, again, based on a woman's age. So every woman, again, every woman needs to be offered a conversation to think about fertility, but the need to actually act and actually freeze eggs is completely different than it is for men. The other issue is, how does one use eggs? So imagine Imagine if a female has gone through the process of having her eggs harvested. You have an option then of freezing the eggs alone or fertilizing the eggs first with sperm, either from a male that you like or donor sperm, and then creating an embryo and freezing the embryos. If you freeze an egg, then in order to make a baby from that egg, you have to first thaw the egg, then fertilize the egg with sperm, make an embryo, and then implant the embryo. The chance of having a successful live birth with a frozen egg is about 10% per egg. In contrast, if you freeze a fertilized egg or an embryo and take an embryo and then freeze the embryo, then the chance of a successful live birth is about more than 70%. And of course, those percentages vary depending on the quality of the egg, for sure. So again, just because you freeze an egg doesn't guarantee that you will actually have a genetically related baby. The idea of parenthood, again, is very important and comes into play. We spoke about that a few minutes ago when it came to the men. So same thing with women. You know, a woman may not have thought about how important it is to her to have a biologically related child. And being I say to all my patients, you can be a parent no matter what. The question here at stake is, how important is it to you to be a parent of a biologically related child? The last thing I wanted to say is, again, in osteosarcoma, fortunately, the type of chemotherapy and the total doses of chemotherapy that are actually being given, meaning MAP chemotherapy, does not have the same impact on fertility as, for example, those with leukemia who have to undergo a bone marrow transplant. In comparison, those scenarios are such that even a woman of the age of 20 or 25 might have complete sterility from their cancer treatment, but fortunately, that's not the case in osteosarcoma. I would also like to add that for both, for men and for women, and for all genders, you know, we're just talking about fertility. I haven't actually mentioned sexual health yet. So chemotherapy does not affect, MAP chemotherapy or any chemotherapy should not directly impact sexual function or development into puberty. Of course, impact on sexual function is definitely a real thing when it comes to body image, impact on hormones, mood, and all of the other factors that are related to sexual health. So maybe that's a separate topic, but I just wanted to separate those two things. So maybe I'll pause again and take questions because I think more information will come out based on the questions from the audience.
What is the recommended time to wait after chemotherapy to freeze eggs or after any treatment to freeze eggs?
So there's no right answer here. I went back a couple years ago, I went back and looked at the oldest reference I could find to say, you know, when it would be safe. And, you know, somebody wrote one day in some random chapter, you know, one should wait 3 months before having a baby. But that actually wasn't based on anything. But that was the paper that everybody keeps quoting, that you should wait 3 months in all subsequent literature that I could find. Now, my search wasn't exhaustive, but I was just trying to understand, you know, where do these random numbers and suggestions come from? In my mind, again, because the eggs are already there, once you've stopped your chemotherapy, if you've resumed ovulation and your cycles have resumed, and you know, have sex with a male, then theoretically you can get pregnant and there should be no impact on your embryo or fetus. So there's not necessarily a specific time. Obviously, we advise people not to get pregnant while on chemotherapy because of the potential that the embryo will, or that the egg that's selected for that to develop that embryo might have some, you know, DNA damage or etc. But otherwise, for females, I'm not sure that there's a specific time that someone has to wait before they start to try and get pregnant. It's more based on resumption of menses. A woman can lose their menses during chemotherapy, just as in men, the sperm count can go down. But just because you lose your menses during chemotherapy does not mean that you're in menopause. Menses should always return once your chemotherapy is done.
I have a question. So is the risk of early menopause higher with etoposide, ifosfamide versus MAP?
Yes, correct. It's not the etoposide again, it's the ifosfamide chemotherapy that if a female is exposed to large cumulative doses, that drug, the ifosfamide drug, is the culprit for fertility concerns. And so if someone has received a lot of ifosfamide, then maybe that window of fertility will decrease, and premature ovarian failure can be a possible concern.
We have a question in the chat. Do you recommend Lupron for women undergoing chemo for osteo?
Oh, very good question. Yeah, so my party line there is no harm. To be honest with you, I don't offer it routinely. Maybe I should, but there's no harm. The other advantage of Lupron is it does suppress menses. And so if someone is having difficulty with very low platelet counts and heavy menses during chemotherapy, that would be another reason to consider Lupron. The studies haven't been done to understand whether Lupron is really fertility preserving with MAP chemotherapy. So I'm not sure.
What is Lupron?
Lupron is a GnRH agonist, so it would suppress ovulation. And so some people feel that if you keep your eggs quiet and you don't have them ovulate, or then maybe you'll protect them. Other gynecologists feel that that's nonsense and it doesn't work that way. So, but if girls or women are on Lupron, it will definitely suppress ovulation. So you won't go through your normal monthly cycles, and you won't develop that thick lining of your uterus, which will shed. So it avoids having very, very heavy menses when you're on chemotherapy.
And to follow up with that, if the patient's on like birth control or any like any form of that, would that like interfere if they had because we said that ifosfamide was the one that has interruptions? So does that correlate with anything at all with their fertility?
No, there's no correlation between being on oral contraception and fertility.
We have a question in the chat. So there is no evidence that chemo is teratogenic.
The word teratogenic implies that if you're exposed to chemotherapy at the time of conception, actually I don't even know if it's at the time of conception. Sorry, I'm not an obstetrician, but rather during first trimester, that what is the chance of having birth defects in the child? So I'm not sure, actually, because when women have cancer during pregnancy, we give women chemotherapy and they can have normal live births. So I don't know if chemotherapy is teratogenic. Other drugs that are infamous for teratogenicity, like thalidomide, they're clearly, if you are exposed to certain drugs, the chance of having a birth defect is very, very high. But I'm not sure about chemotherapy.
I have a question regarding, so if like a patient is younger, right, and you're saying that they're losing some of their eggs, but they still have them, are there any studies showing like when is the right time for someone who has had chemotherapy to start trying to have kids? Because I know 35 is when you start to see the decline in eggs already. I didn't know if there's any studies showing when females with MAP start to go into menopause, or a conversation of when a right time for a female to start wanting to have kids.
I mean, you could ask that question even in non-cancer survivors, right? When's the right time for a woman to have a child? I don't know. Sometimes I wish I had my kids when I was 21, but it's not practical. So, there's no biologically. The younger you are, the better your eggs are. That's what an obstetrician will tell you, no matter what, hands down. So if life does not whether it's from cancer or education or whatever career. I mean, you hear about social egg freezing and all these companies that even pay for their female employees to actually undergo social egg freezing so they don't worry about having kids while they're working. So the idea is that if life isn't helping you to have a baby under the age of 35 or 40, then maybe considering egg freezing is something that you would want to do. But I think the impact of being a cancer survivor and having been exposed to chemotherapy is only maybe one of the many factors involved in family planning.
Do you recommend that female patients navigating fertility after chemotherapy go see a specialized gynecologist or just any gynecologist?
Good question. No, I think that as a cancer survivor, if the question is, am I fertile? What are my chances of being able to have a baby? Should I freeze my eggs? Or should I freeze fertilized eggs? Those are all very, very important questions, and probably the best person to answer those questions as a survivor, once you've completed all your treatment, is going to be a fertility clinic. So you'd want to do the research of, kind of the most approachable or best fertility clinic in your area rather than anything else. I think that when it comes to the impact of cancer on those decisions and those conversations, I think that's very important for sure, but maybe a little bit separate from the actual information that you will need about egg harvesting and is this the right time and what are my eggs like and what's my fertility status. Some programs, as you know, some oncology programs do have AYA or fertility navigators, and maybe those are the people, especially in survivorship clinics, that might be able to help you with that conversation. But otherwise, it's, it would really, it depends what those questions are, and maybe the fertility clinics might be more accurate in answering those questions for you.
Yes. So for female patients who are very young at diagnosis, including before puberty, is it physically or morally possible to think about harvesting her eggs at that age?
Sorry, at what age?
Like for patients that are like female patients that are young at diagnosis. So, in the scenario where you talked about like with the young boys and like their sperm, is it physically or morally possible to even think about harvesting eggs at that age, like when they're really young before puberty?
So in a pre-pubertal girl, the ovary is quiet and the ovary does not go through ovulation. And so there is the only way to harvest an egg, I didn't actually go through the science of all this, but in order to harvest an egg, it actually has to be, go through a process of maturation, and it's called follicular development. So that process of follicular development only happens after puberty, and you only have the opportunity to harvest an egg after puberty starts. Before puberty, there's no mature eggs to harvest. So people might have read in Europe, there's many centers, and maybe in the US as well, there are centers that collect ovarian tissue. But ovarian tissue from a prepubertal girl so far does not have the ability, you don't have the ability to make a baby from harvesting baby eggs from prepubertal ovarian tissue. Scientists are working on being able to take the ovarian tissue from prepubertal girls and in a petri dish be able to actually mature it into eggs to then fertilize with sperm and make a baby, but so far that hasn't happened. Rather, what's happened is people have taken ovarian tissue from young girls, froze it, and then re-implanted it back into patients. There's a lot of controversy associated with this process because, as you can imagine, if somebody has cancer and you've taken tissue out of it, you want to be certain that there's no cancer cells hiding in that tissue before you actually put it back into the patient. So again, Europe is, I would say, many European centers are the leaders in this area, and we definitely don't do that procedure in Toronto in terms of reimplantation, and nor is ovarian tissue harvesting from prepubertal girls something that's necessary in any girl with osteosarcoma, because, as I said, MAP chemotherapy, even with ifosfamide, will not affect her ability to go into puberty, and also will not delete her window of being able to have an opportunity to have an normal fertility, at least, you know, in her 20s or early 30s.
We have a question in the chat. Is there a way to check or know if the damage has been done to a female patient, or is this something that can only be assessed in time when she is trying to have kids on her own?
There is a blood test called AMH, which stands for anti-malarial hormone. Now, the standard reference values for this test are only validated in patients above the age of 25, as far as I know, because this test was initially developed and implemented actually by fertility clinics, which had nothing to do with cancer. So many oncologists, survivorship clinics, and fertility clinics and doctors who are interested in thinking about fertility and cancer survivors are trying to figure out a way to use that AMH hormone level in your blood to say, okay, you know, are you still fertile? Do you still have the ability to have babies? But to be able to predict, you know, based on today's AMH level, what if you're, you know, what's your ability to have an egg or have a baby in 3 years from now? That's the part that's still, you know, not so clear. So we definitely can use AMH to have some idea that yes, you still have a lot of eggs available. You know, I'm not ready to have a baby on my own right now. Maybe I should freeze my eggs, but that's just another one additional piece of data. It's not make or break. It's also not very reliable, I find, in women who are, you know, 16, 17, 18 years of age, because there can be a wide variation in the normal lab values at that age. So I feel like it's not been helpful in the younger patient population.
Are there any comparable financial assistance programs for female fertility preservation?
Not that I'm aware of, unfortunately, and it's so expensive for sure. You know, we're talking thousands of dollars to harvest, then to store, and then to use them afterwards. So even if they're there, then you need another lots and lots of dollars to actually be able to make the baby. It's really tough.
Is taking hormones to induce egg release a standard part of egg preservation?
Yes, and it's a non-issue in women who've survived osteosarcoma. There's definitely specific protocols that are relevant for women who had hormone-sensitive cancer, like breast cancer, ovarian cancer, in terms of the type of protocols that are used for ovarian stimulation at the time of egg harvesting. But because osteosarcoma is not an estrogen-sensitive or responsive tumor, that shouldn't be an issue. You can go to any fertility clinic and get any protocol.
I don't know if Jackie can speak to this, but I had my egg harvested when I was 21, and I don't know if Walgreens still does this, but they covered all my medications. I don't know if this is still the case, but for families that are thinking about it, I know that I just paid for the harvesting fee and then I paid the monthly fee for my eggs, but Walgreens covered all my medications.
Wow, that's interesting. So, I mean, I'm assuming that they would have tested after they harvested. Do they test at that point the viability of those eggs, and if there's like exposure to a lot of chemotherapy, or do they wait until you might want to use it?
So that's more dependent on each. It's like, you know, it's really difficult. It's a huge business. So every fertility clinic offers a various range of, you know, genetic testing for the eggs and embryos, from, you know, platinum, you can get like a silver package or platinum package, but there's no chemotherapy related, you know, genetic screening that needs to occur at all because of chemotherapy exposure.
If you didn't know, if you weren't informed of fertility preservation at the outset, when you're diagnosed and you started chemotherapy, and then, for example, we have a book, a resource book called Osteosarcoma: From Our Families to Yours. And in it, we've had many people, this is the book, it's for osteosarcoma families. It's written by MIB, and we had our scientific advisory board and medical contributors edit and contribute to it as well. And we've had a couple of families come back to us and go, oh my gosh, I wish I would have had this book because I didn't know about fertility preservation. At what point is it too late if you're, say you're doing MAP-IE and you're definitely having ifosfamide and you're a couple of months in? Is there a time that it's too late?
So unless you're 35 years of age and have received ifosfamide chemotherapy, that would be the scenario that you would be in a situation where it's the most it would be the most likely that you might go into premature ovarian failure and not be able to have a baby. But even that's not 100%. It's very person dependent, depending on what your baseline fertility is. And so for most other women, there's always an opportunity in survivorship to definitely, have an aim, see your family doctor or primary care physician, have a referral to a fertility clinic. I mean, we just heard that there's definitely some people who do get their eggs harvested before chemotherapy, but fortunately, even with ifosfamide chemotherapy, there should be a window. I will mention another type of bone tumor called Ewing sarcoma. That chemotherapy for Ewing sarcoma involves far more alkylating agent than with osteosarcoma. And even then, I actually have the same opinion. I don't think that women have to have their eggs harvested before chemotherapy. It's very stressful, very expensive. And, people in that scenario, you have to make a big decision in a very short amount of time. So even in younger women, under the age of 30 or 35 with Ewing sarcoma, I say, look, you will likely have an opportunity under the age of 30 to be able to preserve eggs. So, or have a baby. So, but this is Abha Gupta opinion only, right? Every oncologist and fertility doctor that you see will definitely have their own take on that, for certain.
Okay, so we're coming up on 4, and I want to just give seriously, we should have Osteobites awards for the most badass multitasking speaker ever. And Dr. Gupta, you would so win that. Right now, picking up your daughter from school, driving a car, taking multiple questions.
Yeah, there she is.
Hi. Talking about your mom is incredible, Ms. Gupta. Seriously, this is extraordinary that you're able to impart this complicated information while driving a car, picking up your daughter, dashing off from the hospital. Really extraordinary. Thank you. Thanks for doing it. Okay, so thank you so much, Dr. Gupta. For more information on this and all osteobites, you can go to our YouTube channel, to mibagents.org, probably the best, easiest. It's the clearinghouse for all things. And you can also go wherever you get your podcast. These podcasts, videos, webinars live in perpetuity on these platforms, so you have access to them at any time. If you register for this Osteobite session, you will be emailed the links to the final video and podcast shortly, along with the links that Dr. Gupta mentioned. Next week, we're going to have another really excellent Osteobites session with Paul Malley. He's an expert in palliative care, and he's going to be talking with us about an essential resource we share here at MIB Agents called 5 Wishes. It's a resource which allows you to say just how you wish to be treated if you are seriously ill. It's an actual living will. It's a legal document which helps you to share your emotional and spiritual wishes as well as your medical wishes while you are undergoing treatment. And it's a very friendly document and easy to write out these wishes. So really looking forward to hearing about that next week. Serious topic, one we will all grapple with at some point in our lives, some sooner than others. So excellent, excellent resource. And it's free, as are all things at MIB. Until then, many thanks again to Dr. Gupta for sharing such important information with us today. And thank you to junior board members, Valerie and Kara. And thank you to board member, almost Dr. Are you almost, or are you a doctor? Are you a doctor yet? Okay. And almost Dr. Alexis Johnson, who is our board member at MIB Agents. Remember, get your bows, everybody, mibagents.org/bows. Thanks again. And we'll see you next week.
Subscribe to our YouTube channel.
Subscribe to our YouTube channel.